Members, we're going to call the Committee on Health and Human Services Reform to order and welcome everyone to the committee on a great Friday. Members, we do have a quorum present, and so the first order of business will be to move the minutes for March 11th. Do I have a motion to move the minutes? Representative Baker moves the minutes of March 11th. All those in favor say aye. Aye. Those opposed, no. The motion prevails. And members, I am going to, I have the first two bills up, and if it's not okay with the members, I'm just going to switch. We were going to, on your agenda, it says telehealth first and then the physicians compact. And my intention was to do physicians compact first and then telehealth. And so we'll just switch the order of those two bills. And then I will go to the testifying table and have Representative Peterson take the gavel.
Move my piece. Oh, you can. Oh. Representative Mack, go ahead and move your bill.
Thank you, Madam Chair. I move that House File 321 be re-referred to the Committee on Commerce.
Okay, and there's no amendments that I can, or is there? Yeah, okay. I did have it right. All right, and would you like to explain your bill, and then we'll move on to testifiers?
Yes, absolutely. I'll just do a brief overview, Madam Chair, members, and then we have some great testifiers here that can speak to the details of the bill. Members, the bill in front of you is would create a physicians compact or get Minnesota to get involved in a national physicians compact. The Federation of State Medical Boards last fall adopted basically the framework of what an interstate physicians compact would look like. And this would be a new method for doctors to be licensed in multiple states. Right now, members, a doctor can be licensed in multiple states, but if you have a Minnesota physician who wants to see patients in South Dakota or Wisconsin or any other state in the nation, they have to go through a long and tedious licensure process through that state that can take many, many months. And what a compact would provide would be for an expedited process. And what needs to happen in order to trigger this compact is 7 states need to pass a law basically adopting this compact language. 3 states have passed it so far. We're hoping that Minnesota can be one of the first originating 7 to kind of be on the ground floor of creating the compact and what that looks like. Members, I just want to clarify a couple things up front, and then this can be built on by our testifiers, but nothing in this bill, members, will take away the ability of a state's licensing board to license physicians or discipline physicians as they see necessary. The authority of the originating licensing state is paramount when it comes to how physicians are handled. It also has great patient protections as the physician is regulated where the patient lives. So if there is an issue of a disciplinary action or where something went wrong, that physician would be accountable to the state where the physician lives. And so, members, what this would accomplish is what can be an 8-month wait for a doctor to go through a licensure process to help patients in other states. This would shrink that window to about a 3 to 8 week wait. And again, members, this compact is something that we need 7 states to pass. 3 have passed it so far, and I'm excited about the possibility of getting to be in on the ground floor of that. So with that, Madam Chair, I'd love to bring our testifiers forward to speak to the merits of the proposal and why this is important for the state of Minnesota, and we can go from there.
Thank you, Representative Mack. So your first testifier is please state your name for the records and proceed with your testimony.
Good morning, Madam Chair. My name is Teresa Knadler. I'm with the Minnesota Medical Association. Madam Chair, this compact would establish a contract that Minnesota would enter into with other states that would establish a system that would make it procedurally faster but not substantively easier for qualified physicians to obtain multi-state licensure. I think it's important for the committee to understand that right now Minnesota is a part of 26 live interstate compacts that span a plethora of issues. As was mentioned, this compact would leave intact and unchanged the Board of Medical Practice, its composition, and its authority. It would also leave intact and unchanged the existing Medical Practice Act. All physicians licensed in Minnesota, whether they went through the compact or through the traditional route, would still answer to the Board of Medical Practice, would abide by the Medical Practice Act, and would be subject to any statute or rule that governs the practice of medicine in Minnesota. The compact would establish a commission that would have rulemaking authority to affect only the operations of the compact, that is, the operations of seeking an expedited licensure. The commission's operational rulemaking would not affect Minnesota's ability to engage in other rulemaking, Minnesota's rulemaking regarding the licensure of Minnesota physicians or the regulation of physicians. Under the compact, the Board of Medical Practice would participate in a process of granting extra highly qualified physicians an expedited licensure in Minnesota and facilitate Minnesota physicians to obtain expedited licensure in other compact member states. In order to do this, the Board of Medical Practice would verify the qualified Minnesota physicians' credentials to the commission, and in turn, the Board of Medical Practice would accept physicians for licensure who the commission and other states, member states, have verified as meeting the highest standards. And I want to take a moment to make sure the committee understands that the standards for commission licensure, for compact licensure, are highest common denominator standards. They are higher than the standards that currently exist for Minnesota licensure in the, as I'm calling, the traditional route. And I suspect some of the commission or the committee members might be curious about data sharing, and I just want to touch on that at the front end. The Board of Medical Practice already has the power, existing data sharing practices, to share data with other states about physicians. And the data sharing processes that would be set forth in the compact would not change this at all. It would not change at all the board's authority to share information about physicians, and doesn't require any alteration to the current Data Practices Act. Minnesota Medical Association, the Minnesota physicians have told us overwhelmingly that they support this because it would expedite licensure in a way that would still maintain high standards, still maintain accountability to Minnesota patients, and would retain state oversight of the practice of medicine, but would address the need for border communities, for telemedicine, for multi-state systems to have their docs licensed in multiple states concurrently. Madam Chair, are you interested in having me walk through the bill with the committee, or should we wait on that? I don't quite know where the interest of the committee is with the details.
Representative Mack?
Madam Chair, I think it would probably be to the benefit of the committee to just briefly walk through the articles of the bill. I understand a lot of this is the language directly from the commission, and each state that tries to enter into the compact has to pass identical language. And so it's probably important for the members of the committee to understand what this contains briefly, and then if there's questions, we can certainly go into more detail.
Yeah, that's a good point. The language can't be changed. It's a contract between states, and so like contracts, you can't change it if you're going to enter into it. So I'll start with the first page, the Article 1 purpose. This is important, even though I know we don't traditionally have purpose sections here in Minnesota, because line 1.17, it creates another pathway for licensure, but does not otherwise change a state's existing Medical Practice Act. That is a guiding principle for this compact, and we think it should be included, even though purposes sections are not traditionally part of our bill process. Article 2 creates definitions that apply only to this compact. They are not definitions that apply in other areas of law. The definition that I would call your attention to is definition K 2.26, defines physician, and for the purposes of this bill, a physician is a person who meets all the following eligibility requirements. It is those high standards that will determine which physicians are qualified to pursue commission licensure. Next page, Article 3, eligibility. This section is important. What I'd call to your attention in this section is subsection B. An individual who does not meet those high standards for expedited licensure still has available to her the opportunity to pursue licensure in other states through the traditional fashion. So this is creating two processes, two pathways that get to the same place. It doesn't eliminate the traditional pathway. Article 4, designation of a state of principal license. This gets into sort of how the actual process will begin to look for the physicians who are seeking expedited licensure. A physician is obligated, in order to participate in the commission licensure process, to designate a member state that is the state of principal licensure. This means that that physician must first obtain her primary license, her first license to practice medicine in the United States at least, from a state through the traditional fashion. And that will then serve as their state of primary licensure, which has implications further down the line in terms of continuing participation and discipline. Article 5 outlines the application and issuance of expedited licensure process. And the process outlined, I'll summarize it quickly, is the physician files an application for an expedited licensure with their member board, their state of primary licensure. The member board verifies that the physician does indeed meet the multiple elevated standards for expedited licensure, and then attests to that essentially to the commission. Upon verification, the commission will ask for the committee to, or excuse me, the physician to fill out any additional information that the commission needs. Some of this isn't yet known because it will be fleshed out in rulemaking that the commission engages in. And after the commission has verified that the physician meets the high standards, I'm turning on to the next page here, still in section 5, then the member boards of the states in which the physician wants licensure will issue the license to the physician. And I want to pause and make sure that that's clear. The member boards of states are the ones who will always be issuing licensure. The commission is not issuing licensure. It is facilitating the process of issuing licensure. And the that's enough there. I'll move on to Article 6. Article 6 sets up or explains that there are two fee possibilities. First, member states will always retain the ability to assess whatever licensure fee they see fit, whether the applicant is coming in via traditional methods or whether the applicant is coming in via commission expedited pathways. It also makes clear that an interstate commission is authorized to develop rules regarding fees for an expedited license. Now, I think of this as a convenience fee, which would be the physician paying the commission some amount of money that is yet to be determined and won't be determined until rulemaking takes place for the convenience of using this expedited licensure system. It's important to note that these fees will still, just as is the case now, be borne by the physician seeking licensure. Article 7 is just sets forth that continued participation, you need to be meeting the same standards. If you fail to meet the standards, you will no longer be eligible for a commission expedited licensure. Articles 8 and 9 set forth some of the data sharing that I referenced earlier. Basically, there will be an IT platform that will let the states communicate with each other about physician information, and Article 9 sets forth joint investigation processes. Article 10 explains disciplinary actions, and it can get, I'm not going to get into detail unless there are questions, but I think the important thing to take away with the disciplinary actions is that the member state is paramount, as Representative Mack said in her introduction. The member state's authority is recognized in the disciplinary process as being superior to the authority of all the other states. Article 11 sets forth the process fees for the Interstate Licensure Compact Commission. And the important thing there is that the Board of Medical Practice is the body that will appoint representatives to the commission and will have a voice in how the commission operates. It keeps the Board of Medical Practice close to the operations of the commission. Article 12, moving on, powers and duties of the Interstate Commission. They're extensive, but the important ones are administer the compact, promulgate rules relating to the operations of the compact, give advisory opinions and education to help physicians understand how it is that they need to maintain their licensure and how to comply with the disparate recommendations of multiple state licensure, multiple state regulatory schemes. And then there's some provisions for reporting to the legislatures and the governors of the member states, keeping the states involved in the process. Article 13, financial powers. It gives the committee, among other things, the ability to level an annual assessment from each member state. And I won't go into that at this point unless there's questions, but what I understand is that the Board of Medical Practice can speak to exactly how this might play out. It's not expected to be a large fee, and it would not come from the general fund. Article 14 speaks to the governance of the commission. This is really boilerplate, compact language, as is the rulemaking function of the Interstate Commission. Important there, I want to reiterate that the rules promulgated will be only those rules necessary to operate the commission. They will not reach into our state and alter our rules or our Practice Act. Article 16 provides for state oversight, which of course is important for ongoing participation. Article 17 provides, and 18 both provides for basically how do we resolve disputes that may arise between states or between a state and the commission about how the compact is being operated. As the Article 19 also provides for similar. And then important, I'll skip ahead to Article 21, withdrawal. As with all compacts, if Minnesota doesn't care for how the compact is operating and it finds it to be inconsistent with our values, we are able to withdraw by an act, a sort of parallel act of the legislature that would remove us from the compact. The rest of it is, again, boilerplate, and I don't think worth going over at this point.
Thank you. And are there any questions for this testifier before we move on to the next testifier? Representative Liebling.
Thank you, Madam Chair, and I'm not sure if you're the right person to answer this, but, I know that the bill is going to Commerce, and I assume that it's not going to HHS Finance. Representative Mack, because I don't see there's no appropriation in it, right?
Representative Mack.
Thank you, Madam Chair, and Representative Liebling. Thank you for bringing that up. I was going to correct my motion. Actually, my intention is that the next stop for this bill would actually be government operations. And so, but no, at this point, it's my understanding that it does not need to go to HHS Finance.
Okay, Madam Chair.
Representative Liebling.
Thank you, Madam Chair. Thanks, Representative Mack. I just, and I can see why you wouldn't be thinking along those lines, but there are some financial issues that I'm seeing in here that I just like to understand a little bit better, or usually we don't do that in this committee, and that's why I was asking, because I just want to make sure that that piece of it gets fully vetted, because what I heard the testifier say, first of all, was that people would be coming to our Board of Medical Practice for the ultimate license from another state. And that kind of raises a flag in my mind about whether our Board of Medical Practice would be incurring some costs then for issuing that. And then also I'm looking at the finance powers piece about the Interstate Commission may levy and collect an annual assessment and so on, so on. And even though there isn't an appropriation with this, I wonder if we might be incurring some financial obligations. I mean, it wouldn't be necessarily a bad thing, just that it needs to be fully understood before we would approve this. So, Representative Mack, I don't know, maybe you'd be the person to respond to that, because, just to say too, as part of that, I understand that there are fees also collected under this and so on, but the way our budgeting process works, the legislature, even though there are fees collected by the health-related boards, they go into special revenue funds, and the legislature still has to appropriate those back to the boards, and so that is a financial impact that has to go through finance committees, generally speaking. So I don't know which one of you would like to address those points.
Well, in Representative Liebling, I do know that we have a testifier from the Minnesota Board of Medical Practice as well. So maybe perhaps the best approach is to maybe finish with the testifiers, and then perhaps that could be addressed along the way.
Well, Madam Chair,
Representative Liebling.
I don't really think so. I mean, they could address the money coming in and going back out, but the bigger issue is more of an issue, I think, probably for Representative Mack about how this fits in our legislative budgeting process.
Representative Mack.
Thank you, Madam Chair. And Representative Liebling, my intention would be, the next step would be government operations. And I understand that it did go to HHS Finance in the Senate. And so I'll work with Representative Dean, but my understanding is that because of some of the finance powers outlined here, that we would go to HHS Finance. And I do understand also that when it comes to the boards, and I'm sure they'll speak to this, that there's an estimate out of the commission on what would be levied on an annual basis, and the medical practice feels, the Board of Medical Practice feels comfortable with that, that it wouldn't require an extra having to collect fees of an increased amount. But I believe they will speak to that. But for your comfort, my intention would be that we'll go to HHS Finance.
Okay, thank you. Thank you.
So
Thank you,
Representative Mack, for my own clarification then, are you still planning on going to government ops next and then from there going to finance?
Yes, Madam Chair. My intention, my point was just that we'll follow the process, and part of that process will be HHS Finance.
Thank you very much. Okay, then I think we'll move on to your further testifiers. Thank you very much.
Thank you, Madam Chair.
And we have Dr. Steve Aumann, the director from Mayo Clinic, as well as Mark Egan, the doctor from Minnesota Board of Medical Practice. And we also have Bentley Graves from the Minnesota Chamber of Commerce. So please state your name for the records and proceed with your testimony.
Good morning. My name is Dr. Mark Egan. I'm here, and I appreciate the opportunity to be here, Madam Chair. I am the current president of the Minnesota Board of Medical Practice. I'm also a member of the Minnesota Medical Association Policy Council. My practice is as an anesthesiologist. I'm a professor and clinician at the University of Minnesota, along with my other regulatory medical roles, both nationally and locally. I'm currently in my second appointment, governor's appointment to the Minnesota Board of Medical Practice. I've been on the medical board since 2009, and I've been quite involved with local and national ways of running the medical board, and I have to say that Minnesota's got one of the best run medical regulatory systems in the country that we should all be proud of. Through my experiences with the medical board, I have an opportunity to engage in national and national level. There's this Federation of State Medical Boards, FSMB, which the 70 licensing boards nationally gather and look at different policies on a national basis. Through this, I've been involved in several committees, many more than you want to hear about. I'm currently running for the board of directors of the Federation of State Medical Boards, my point being that I'm fairly well embedded in the FSMB process. Through my local and national involvement in the medical board and the Federation of State Medical Boards, I've become familiar with this Interstate Medical License Compact. This has its roots back into about April at the annual meeting in 2013, and it was developed with input from all the state medical boards involved with the Federation of State Medical Boards, and it's supported by the Federation, and it's also supported by the Council for State Governments. As we all know, healthcare is in a huge transition right now. What we're doing needs to change significantly. We need to get cheaper, we need to get safer, and we need to get better patient population health. That's a lot of lifting to do, but we have no choice. We can't keep doing what we're doing. So how do we do that, and how can our legislative process affect that? Well, the Interstate Compact is going to allow increasing access to care. Physicians in other jurisdictions outside of Minnesota can take care of patients in Minnesota, and I'm kind of alluding to the thought of telemedicine, telehealth. It's going to facilitate state practices across state lines, and again, it'll enable telemedicine without compromising patient safety. The U.S. Senate has recognized the value of this compact. In January 14, the Federation of State Medical Boards received a bipartisan letter of support and congratulations from the U.S. Senate. It was signed by 16 U.S. senators, including Senators Klobuchar and Franken of Minnesota. So the Interstate Compact counters efforts by lawmakers and stakeholders seeking to federalize or nationalize a medical licensure system. I view that as a problematic situation. I view medical licensure as a state-by-state, state jurisdiction, states' right piece. And I have to say from my personal experience that the standard and quality of care varies radically, markedly, between different parts of this country. And I can say that I feel that the care provided here, having worked in California, is very high quality, upper quartile. So the Interstate Compact will streamline the process for fundamentally changing the policing powers without fundamentally changing the policing powers of the states. So in other words, you can be licensed in Minnesota. The patient lives here in Minnesota. Somebody from across state lines practices, and they practice inappropriately, such that they violated the statutes regulating the practice of medicine in Minnesota. We then, as the medical board, have the ability to discipline that physician's practice appropriately by Minnesota standards. Turn that around, if we have someone practicing telemedicine in Minnesota who doesn't have a Minnesota license, I have no jurisdiction over discipline of that physician. That's problematic in my mind, and that's one of the great reasons in my head why we need to go ahead with this Interstate Compact. Once vetted in a compact state, qualified physicians will be able to quickly obtain licensure in other jurisdictions without having to go through individual vetting processes in every jurisdiction. In some states, this can take hours to days to just get the compact licensure. Once you have the license and you qualify in one state, you're going to be qualified in all the compact agreement states. If somebody comes here in the current process of licensure, it can take weeks to months before you can get licensed, because we have to go through this individual state vetting process. So a physician has a choice. They can license through the compact, or they can choose licensure by the traditional process. There's not a restriction there. The simplest way to think about this, in my mind, is when you go to the airport and you got your TSA pre-check, and you go through the pre-check line. So this is kind of the same thing, that you've applied and have compact privileges, and you can get pre-check all the way through to licensure in multiple different jurisdictions. But once you're in the state and you're licensed, you have the same responsibilities as everyone else who's licensed as a physician in the state. And again, I commented earlier, the license obtained through the compact is expedited, and it's available through the traditional processes with the same responsibilities as a traditionally licensed physician. I could go on forever. I'm passionate about this opportunity as we move our healthcare system into a better place. Thank you.
Thank you for your testimony, Dr. Egan. We have Mr. Graves and Ms. Commit. Who would ever like to testify next? No? I'm sorry, Representative Mack.
Thank you, Madam Chair. I think the next testifier is maybe the Dr. Amin.
All right, Dr. Amin. Welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Mr. Chair, thank you for the opportunity of being here today. My name is Steve Amin. I'm a practicing cardiologist at Mayo Clinic, and I'm also the medical director for our Center of Connected Care, which is Mayo Clinic's telemedicine enterprise. While we recognize that this bill does not speak solely to telemedicine, we do think it begins to address some of the barriers that limit patients' ability to receive high-quality care through modern technology, which we can now leverage to make significant outcome differences for our patients. As you know, situated where we are an hour from 2 state lines in southeastern Minnesota, but also Mayo Clinic physicians see patients from all 50 states every year. So we're acutely aware of the issues of trying to transfer care from on-site facilities to care when patients go back home to their own residences. As has been outlined by the prior testifiers, the obtaining medical licenses is an issue. Our administrative staff estimates that it takes 20 to 40 hours of administrative time for the initial out-of-state medical license, and that doesn't count the physician or provider time and effort to go into that. So there's a significant clerical burden that goes with obtaining these licenses. This becomes a barrier for services that we can provide. As acute examples, there are specific diseases that have very discrete time windows where delivering acute care is effective. Stroke, for instance, there's a window of time from the onset of symptoms of stroke where critical drugs can be delivered to be effective. Many small hospitals do not have acute stroke neurologists on staff, but leveraging telemedicine technologies such as video allows our Mayo Clinic stroke neurologists to see those patients in their local hospital and make decisions about delivering these critical drugs at that critical time. We've shown that this telestroke activity with the hub and spoke methodology not only improves outcomes for patients, it saves lives, allows more patients to be dismissed to independent living conditions, but also saves the whole system money. Another analogy is enhanced critical care services. Again, where small hospitals do not have intensive care specialists on staff, but our intensive care nurses and intensive care doctors can remote into their technology, their monitors, and care for patients and keep the patients there rather than wasting critical transport time. Through these services, we've seen reductions in deaths by more than 50%, and reductions in non-fatal complications by more than 40%. So delivering care is important, but if you happen to live on the wrong side of a state line, the physician who's providing care that day might not be able to offer those services. So this is where Mayo Clinic sees this state licensure compact as being the right step to provide more patients the opportunity to avail themselves of highly specialized care. I would like to also say that in addition to the Interstate Medical Licensure Compact, we would also like to endorse the next bill to be discussed, and that is addressing reimbursement issues that are also representing barriers to telemedicine policies. So I will simply close and make my testimony brief and simply say that Mayo Clinic sees a tremendous opportunity that enhancing licensure compact will provide our physicians, and addressing reimbursement policies will avail more patients so that we can provide the right care at the right time for patients where they are when it's appropriate, rather than forcing them to come to where we are. Thank you very much.
Thank you. Representative Mack.
Thank you, Madam Chair. And as it was alluded to, this bill dovetails with the next bill that we're going to be discussing on telehealth, and this testifier kind of broached on both of those, and he will, of course, be available for further questions on the telemedicine bill that we'll be hearing next.
Oh, great.
Thank you.
And do you have any further testifiers on this?
Madam Chair, I would default if there's anyone else here who wants to testify.
Okay. So is there anyone from the audience that would like to testify on this bill? Please come forward. Welcome to our committee. Please state your name for the records and proceed with your testimony.
Thank you, Madam Chair, members of the committee. My name is Twyla Braze. I'm president of Citizens Council for Health Freedom. And I know there's nobody here that's testifying in opposition to the bill, but I thought it was really important to hear from the Association of American Physicians and Surgeons, who is opposed to this bill. And so let me just give you some of the reasons why, because I think it's important for you to hear. This is from a resolution adopted by the American Legislative Exchange Council, saying that about this bill, that it will supersede a state's, about this whole initiative, that it will indeed, despite what is said, supersede a state's autonomy and control over the practice of medicine, that the commission will likely implement changes to the state's Medical Practice Act, that there will be a significant cost to each participating state in joining the compact, that it will be difficult and expensive for a state to extricate itself from the compact, that the cost of obtaining medical licenses will be dramatically increased, and that states must protect their citizens from regulatory excesses that could come, and that the Interstate Compact's definition of a physician is at variance with all other state medical boards. So I think it's just important for you to have heard a different perspective on this bill. I shared their comments with Representative Mack some time ago, but it's important to understand that there is opposition to this bill at a national level. Thank you.
Thank you.
Madam Chair.
Representative Liebling.
Thank you, Madam Chair. Ms. Braze, are you a paid lobbyist for the group that you just quoted?
Ms. Brace.
Representative Liebling, I am not a paid lobbyist for them, but I think it's important for this committee to understand that there is opposition, and we can bring any organization's concerns and comments to the committee's understanding. We have concern as well about the fact that medical practice would be taken over by anyone outside of this state. It's just that their opinion is so well organized that it is good to be able to share with you what they have said.
Well, Madam Chair,
Representative
Ms.
Lealing.
Braze, frankly, Ms. Braze, I mean, anybody can come and tell us, and we should be hearing, I do agree with you that we should hear all sides of every issue. However, I really think it's inappropriate to come in and represent somebody else's views. I mean, if you want to share their views, if you want to read what they had to say and come tell us why you think why you hold those views, that's fine. But I frankly think it's very inappropriate to come in and pick somebody else's views out of the air and say, here's what this other group thinks. Just my own opinion. Thank you.
Madam Chair,
Ms. Brace.
we would not have come here to share these views if we did not agree with these views. But in fact, these are views that are just well stated in a way that we can share them with you from attorneys and other groups that have shared this. And this is from testimony that was on the Senate file of this bill to Senator Latz. So it has already gone to testimony for this bill.
Thank you.
Thank you.
Are there any other testifiers from the audience that would like to share their comments or views? Welcome.
Madam Chair, members of the committee, my name is Ruth Martinez. I'm the Executive Director of the Board of Medical Practice. I want to thank you for this opportunity to just comment on some of the testimony we've heard here today. I would like to just say that the position in opposition of the Interstate Compact is a position that was thoughtfully considered by the Board of Medical Practice prior to its endorsement of the Interstate Medical Licensure comment, and I thank you for the opportunity.
Thank you. Any other questions, or we have any other testifiers that would like to come forward? Representative Mack?
Thank you, Madam Chair. I just wanted to clarify for any concerns that might be raised for members, just to make sure that they know that there's nothing in this bill that says that they can change the Medical Practice Act. And in addition, there's a lot of protections built into the language of the commission that ensures that each state has their own autonomy in terms of how their medical practice works, as well as very clear severability options if any state finds that the commission and the compact is not serving them well. And so I can't say that I agree with the concerns raised by a previous testifier and groups out there that see this as a hindrance to our state's autonomy. Rather, I think it's a good protection against the national licensure, which I think raises a lot of concerns for a lot of people. I think that this is a good middle ground that protects states' rights.
Thank you. Members, are there any questions? Seeing none, I will renew Representative Mack's motion that House File 321 be re-referred to the Committee on Government Operations and Elections. All those in favor say aye. Aye. Opposed say no. Motion prevails, and you're on your way to your next committee. Thank you.
Thank you, Madam Chair. And I have the next bill up also. I'm just
Yes.
going to grab my notes briefly.
Okay, come on forward. I suppose it's one of these. Okay, so our next bill is House File 1246, and be moved to the Committee on Commerce and Regulatory Reform. And we do have the bill before us, and I understand that you have an author's amendment titled A2.
Thank you,
Representative
Madam
Mack.
Chair. Yes, I would like to move the A2 amendment.
And any discussion on the amendment? You want to tell us a little bit about what it is, or do you want to talk about the whole bill after you've amended it?
You know what, why don't we talk about the whole bill after we've amended it?
Okay, so we'll get the bill in the form that the author would like it. All those in favor say aye to the amendment A2. Aye? Aye. All those opposed say no. Motion prevails, and the amendment is adopted. To your bill, Representative Mack.
Thank you, Madam Chair. Madam Chair, I will give a brief kind of introduction to the bill and the overall goals of what we're trying to accomplish. And then we have some testifiers here, and through conversation can walk through the bill and make sure that members understand what we're doing specifically. But members, what's in front of you today is a bill that is really trying to capitalize on what I believe we have as shared goals in terms of what healthcare reform looks like into the future. It's no secret that this session, a big focus has been accessibility issues, rural healthcare, and ensuring that no matter where you live in this state, you have access to the same quality of healthcare as anyone else. And I believe that the bill in front of you today accomplishes that goal, or it moves us further down the road in terms of that. We also have a workforce shortage, healthcare workforce shortage here in Minnesota, that there are a lot of good things being done this session to try to address that. But I think we all realize that that's a pipeline. That's something that can be recognized many years out, the product of that work. I see this bill and telehealth as more of a short-term solution as we continue to work on our workforce shortage issues. And members, I also just want to clarify that as we discuss this today, what this bill gets at is making sure that there's fairness in how some of these practices are paid for and insured for people of the state. The fact is, communities across Minnesota are struggling to retain access to healthcare services. Primary care shortages already impact many rural communities and are growing. And for many of the state, there are increasing concerns about access to specialty care. And that is a big piece of why you have this bill in front of you today. Telemedicine will allow individuals to receive care locally without necessarily having to travel long distances to seek care in large metropolitan areas. And you'll maybe hear stories today. I've heard several about some of the challenges of families in rural Minnesota having to make very difficult treks down to the cities to have access to specialty care for their kids. We're trying to address some of those issues. Telemedicine certainly makes care more convenient for patients. Telemedicine can enable providers to deliver life-saving care such as emergency and stroke care more quickly without the risks, delays, and costs of transporting the patient via ambulance or helicopter. And telemedicine extends the reach of scarce specialty services. This, of course, can mean cost savings, but more importantly, it can be life-saving for people across the state. The key elements of this Telemedicine Act in front of you are it updates the definition of telemedicine to keep pace with technological innovations, and it requires public and private insurance plans to treat and pay for services delivered using telemedicine technology, the same as services would be delivered face-to-face. For clarification, I also just want to emphasize some of the things that this bill does not do. This bill does not expand any provider's current scope of practice. This bill does not force a health plan to pay for services that are not covered services under the plan that the patient has purchased. This plan does not take away health plans' right to negotiate the rates that they pay providers for services. And this bill does not require a health plan to pay providers with whom it does not have a contract or otherwise require a plan to expand its provider's network services if they are out of network. So members, I think that this is a great example of some of the things that we're trying to accomplish this session in terms of healthcare reform. We're able to leverage the amazing power of technology and apply that to patient care and accessibility to good quality patient care. And so members, with that, I'd like to maybe move to testifiers to shed some more light on the importance of this bill. And also I will say that you will also hear some concerns on this bill going forward. And I just want the members to know up front that we are, I should say I am committed to continuing to work as we go forward to address some of those challenges. So with that, we could take testifiers, Madam Chair.
Yes, and I understand there are several, and so on the list we have Maureen Eideker, Director of Telemedicine, Essentia Health, and I do think that we also have some information from this group as well. And we'd like to make sure our testifiers have enough time, but we're trying to limit it so we can proceed along, so about 2 minutes, please. Thank you.
Madam Chair, good morning. I come to you from Essentia Health. I'm a registered nurse. My name is Maureen Eideker, and I'm the Director of Telehealth at Essentia. My office is at Holy Trinity Hospital in Graceville, Minnesota, which is located 2 hours just straight south of Fargo. And my perspective is from the rural hospital, nursing home, and clinic settings across northern Minnesota, where telehealth services are currently provided by Essentia at 15 Minnesota sites. I have over 20 years of experience in telehealth. There are 3 areas in the telemedicine parity legislation that are of utmost importance. The first relates to a broader definition of licensed healthcare provider eligibility. Currently, the following licensed providers are not recognized as eligible reimbursable providers under Minnesota Medical Assistance and most commercial insurance plans when they're doing telehealth. And those include audiologists, pharmacists, genetic counselors, RN certified diabetic educators who do the majority of diabetic education, physical and occupational therapists, and speech language pathologists. Dentists and optometrists are also excluded. This limitation results in rural Minnesota not having access to needed medical specialties unless they travel long distances, which is difficult for many for a number of reasons, including time, comfort, and finances. The second relates to lifting the restriction on urban settings as eligible sites. The third main issue relates to the originating site eligibility. Currently, the rules exclude group homes, assisted living facilities, and homes as sites where the patients can be located to be eligible for reimbursement coverage. This restriction impacts potential telehealth services to the developmentally disabled living in group homes, behavioral health residents of group homes, and the elderly in assisted living facilities. Allowing group homes and assisted living facilities to be eligible sites for patients would reduce expensive transfer costs and decrease unnecessary admissions to emergency rooms, especially after daytime business hours. Telehome monitoring devices should also be an eligible service in order to maintain chronically ill and elderly in independent living environments. Thank you, and I encourage you to support this important patient-centered initiative.
Thank you, Ms. Heidecker. Our next person on the list is Dr. Gregory Wright. Welcome to our committee. Please state your name and proceed with your testimony.
Good morning, Madam Chair, members of the committee. My name is Gregory Wright. I am a pediatric cardiologist and chief of the Division of Critical Care Services for Children's Hospital and Clinics of Minnesota, one of the country's 10 largest pediatric health care systems. Telemedicine is becoming a key component in effective healthcare delivery. Children's in 2013 made the decision to create a telemedicine program striving to improve patient outcomes, decrease costs. Our goal is to transform the delivery of care by partnering with patients, families, and other provider organizations to project our pediatric expertise wherever and whenever it is needed. Parenthetically, the previously discussed bill would aid enormously in that endeavor. Children's first step in January 2014 was to establish telemedicine support for clinicians in a suburban emergency department. Our emergency physicians have been able, for example, to evaluate children with fever and other symptoms who were worrisome to the examining clinicians, helping with decisions to send home or to admit, and to admit either locally or to a tertiary care center. That first step has been so successful that within 1 month we will be providing expertise and advice to a rural emergency department, and we expect to be supporting as many as 8 to 10 emergency departments in rural Minnesota by late 2015. Now we're expanding our telemedicine program to provide virtual general pediatric and subspecialty care. Next month, our families with hemophilia will be able to connect from home to their hematologist, thus allowing the hematologist to make better decisions about treatment of a bleeding problem at home instead of the costly emergency department with its large facility fee. Soon we'll have virtual clinics in a variety of specialties so that in a single morning, for example, a pediatric specialist in any one of a number of specialties from an office at Children's will be able to evaluate several children from Worthington to Grand Marais without having those children and families miss 1 or 2 full days of school and work to travel the great distances for only a 30-minute visit in the cities. An intensive care specialist can evaluate and consult on a patient in Alexandria to prevent a transfer to the cities. We also will begin a pilot program very soon with a Medicaid population in a local elementary school to provide telemedicine evaluations of mildly ill children as part of Children's Integrated Health Partnerships demonstration. In this Department of Human Services program, we are accountable for the health care of 17,000 children receiving state medical assistance. We believe in our school telemedicine pilot, we will demonstrate savings by preventing emergency room visits. These type of cost savings have been realized in other parts of the country. In Rochester, New York, for example, a program in 5 daycare centers involving 700 children, 66% of whom were on Medicaid, was able to prevent all but 10% of those children from being sent home with their minor ailments. Their parents, when surveyed, indicated that without this program, 93.8% of those problems out of 940 telemedicine encounters would have led to an emergency room visit or an office visit. But for these sorts of programs to succeed, medical personnel must be paid. The current reimbursement status for telemedicine lacks clarity. Without negotiating payer by payer, we do not know if telemedicine consultations will be reimbursed. In order to fully achieve the goals of the triple aim, to improve patient experience, improve health of populations, and reduce costs of health care, our ability to meet families in or near their homes is critical. If we're serious about transforming the way healthcare is delivered, we must be able to rely on fair payment to enable us to continue to innovate and coordinate care.
Thank you.
For your time this morning.
Thank you. And next on our list, we have Bentley Graves from the Minnesota Chamber. Oh, and it looks like we also have Catherine Knitt. Welcome. Please state your name for the records and proceed with your testimony.
Thank you, Madam Chair and members of the committee. My name is Catherine Kmitt, and I'm here today on behalf of the Minnesota Council of Health Plans. Thanks for the opportunity to testify. The health plans support the use of telemedicine as a tool for improving patient access to care. When used appropriately, telemedicine can remove certain barriers to health care delivery, such as distance, mobility, and time constraints. Health plans have been early adopters of telemedicine and in many cases already cover it. We strongly believe telemedicine is a tool that should save healthcare costs as well as extend access to care for patients. In today's competitive health insurance marketplace, health plans are focusing their efforts in the direction of outcome-based care using innovative payment reform models to incent providers to improve healthcare quality and reduce costs. These payment reform models include the use of telemedicine. One of our main concerns with House File 1246 is that it mandates fees that the health plans must pay providers. To help control the cost of care, we believe the fee should be negotiated between the providers and the plans. There may be cases where it is appropriate to pay a fee to the originating provider, but there also may be cases where it may not be appropriate to pay a fee to the originating provider. If health plans are mandated to pay providers a separate fee outside of the benefit structure of the plan, subject to deductible copays and coinsurance, then this is no longer about service parity, but rather this becomes a benefit mandate that the state will have to fund for qualified health plans, and that will result in a fiscal note for the state. We believe the bill should be further refined to put reasonable limits on the requirements to cover telemedicine so that the costs for carriers and the costs paid by consumers in the form of premiums can be limited. We would like to amend the bill to more closely define telemedicine and clarify that telemedicine is covered only when the type of service being performed is also covered under the enrollee's contract and when the service is medically necessary and medically appropriate to be delivered via telemedicine. The health plans should be permitted to apply different cost sharing for out-of-network services and apply reasonable medical management as is permitted for in-person services. Now, having said that, I can also tell you that we have been working directly with the representatives from the Minnesota Hospital Association on this bill since its introduction. And in my view, we've made progress working through some of our differences, but we have more work to do. The amendment that Representative Mack has added to the bill is due in part to the negotiations we've had on this bill, and we would like the opportunity to continue these negotiations in an effort to find compromise on this legislation. With that, Madam Chair, I would just say that we look forward to making more progress with the Hospital Association and Representative Mack on this bill as it moves forward. Thank you for the opportunity to testify.
Thank you for your testimony. Hello, Mr. Graves. Please state your name and proceed.
My name is Bentley Graves from the Minnesota Chamber of Commerce. I work on healthcare and transportation issues for the Chamber, and I want to thank Representative Mack for bringing this bill forward and for shining the light on the potential for telemedicine and for the significant benefits that can come from it. I too, though, wanted to voice just a couple of concerns, and most importantly with the originating site fee that Ms. Commit just discussed. We have concerns about the impact that could have on cost. We certainly believe that telemedicine can and will contribute significantly to our healthcare system going forward, and we want to make sure that continues to be an important component of care that providers can use, but we want to make sure that we're doing it in a thoughtful way and not doing it in a way that arbitrarily locks in costs. So we too have had very good conversations with the Hospital Association and want to make sure that we're part of the conversation going forward. I appreciate the discussion that we've had thus far and are certainly committed to helping to move this along as well as it makes further stops in additional committees.
Thank you, Mr. Graves. Are there any other testifiers that you have brought, Representative Mack? Okay, is there anybody from the audience that would like to testify on this bill? Please come forward and state your name if so. All right, then we will move to member questions and comments. Representative Liebling.
Well, thank you, Madam Chair, and thank you, Representative Mack. This is legislation that's kind of a heavy lift, and I know you're busy, and I think it's really important stuff. And you know, just let me be clear that I think there's a lot of real potential for telemedicine. I don't have any doubt that this can improve healthcare in the state, that it can help us with cost and so on and so on. But I find myself in the really rare position of agreeing with Ms. Commit and with the gentleman from the chamber. It's really an odd day when that happens.
Write it down, Representative.
I know, we should remember this day. They should remember this day. Remember when you agreed with us? But I think this bill really needs a lot of work. I'd like to see it. I know we've done this very successfully in certain areas, and I want to say again, I have absolutely no doubt that in certain areas, this is just the way to go. But I just am concerned that the bill is just too broad and really not ready to become law. And I'd like to see us tailor it more closely. I'd like to see us maybe even pilot it in certain areas so that we can be sure that what we're doing is really improving care and is really saving costs, or at least not. I'm fine for costs to increase if care is increasing and we're getting more care to where it needs to go. But I don't think any of us are fine with increasing costs just to do the same thing that we're already doing. So we want to really make sure that that this is going the right way and not just expanding things kind of out of control. I mean, we have a great healthcare community in Minnesota. We are really very fortunate at the quality of what we have, and I just want to make sure that we move forward carefully enough that we don't upset the apple cart, and I think that's what I'm hearing from them. So I wanted to ask you, Representative Mack, where is this bill going? How many more stops is this going to have in the House?
Representative Mack.
Thank you, Madam Chair. It's next going to Commerce, and then I believe Health and Human Services Finance, and would be open to, you know, making sure that it goes through the adequate process. But to your points, Representative Liebling, I did mean what I said at the beginning. I would agree that this is not quite ready to become law as is. But as all of us know around the table, we rarely can have our bills in tip-top shape at its first stop. It's a process, and so I realize that there's work yet to be done. I want to address the concerns that were referenced by Mr. Graves and Ms. Commit as best as we can. I also, you know, understand that we have this unique situation where to invest in some of this telemedicine technology that providers would need in order to participate in this is expensive, and it can be risky if there's not some level of consistency in what they're going to be reimbursed for. And so that's kind of the tight wire I think we're trying to walk, is not just ad hoc create some willy-nilly extra funding stream, but somewhat of a consistent, reliable understanding of what will and won't be covered as an incentive for more and more providers to invest in what could be some really impactful reform in the future and better service to patients, less inconvenience, all the things that we talked about. So as I've navigated this bill, I've tried to really hone in on what the problem is and make sure that that problem is articulated as clearly as possible, and then figure out how do we tailor the solution very carefully to get at the actual problem we're trying to fix. And so that's my commitment as we move forward with this bill. And so I don't know what comfort that creates for you or members around the table, but that's my commitment, and there's been good work done so far, and I think that's going to continue.
Representative Liebling.
Thank you, Madam Chair, and Representative Mack, I do appreciate that. This is a complicated bill. As I said at the beginning, it's a heavy lift for a legislator because there is so much to consider here, and, I appreciate that, and, I certainly would support the bill today, but, I think probably like many of us, we might not support it on the floor if it was on the floor like this. Maybe you wouldn't either. I don't know. But it does, because there is a lot of work that needs to be done. And I don't have a full understanding of what the technological requirements would be. Sometimes you think, well, you can do Skype for free. I know that doesn't deal with the privacy issues and so on. And I know there are a lot of overlays to this, things that have to be considered. But I'd like to see it maybe be piloted in one, and I know it's been piloted in the sense that people are doing telemedicine, I know that. But in terms of the payment, maybe that could be piloted in one sector of what kind of care, or sort of so that this could be maybe rolled out, because I feel a little conflicted because I don't want to stop the progress. At the same time, I don't want to just open wide the barn door. But thank you for your work. I look forward to working with you on this.
Thank you, Representative Liebling.
Ms. Eideker.
Madam Chair, just to clarify a couple of things, and as was just stated, telehealth is already covered for rural sites by commercial payers and Minnesota Medical Assistance. The comments that I made were regarding the 7 licensed healthcare professionals who were not covered. So a very kind of controlled group there that need to be covered. The other thing I want to clarify is that the originating site fee. The originating site fee is a $20 code fee that is charged by the rural site. It's the only thing they can charge for. Of course, the professional fees goes to the specialist. The originating site fee is it's a $20 fee, it goes to the rural site. My recommendation on that is that that a base rate be established that's no lower than the Medicare rate, for instance, which is that $20 fee. But that fee doesn't swedge up to $200 because it's a cardiologist doing the visit or anything like that. It's just a straight $20. It pays for the broadband, pays for the secure virtually private network, pays for the nursing time and the supplies. There's no other fees that can be charged for that.
Thank you. Representative Mack.
Thank you, Madam Chair. And to that point, certainly the originating site issue is one that will continue to be worked on. And just for members around the table, just so they understand the mechanics here, the originating site, this is spelled out in definitions, but is where that's the means by which you could keep the patient local. They could go to their local provider and then have access to somebody at Gillette or at Mayo or whatever the case might be. And so the challenge is, how can we make sure that, yes, that originating site, that small town provider, rural provider, is getting some sort of reliable small amount of money to just keep their equipment updated, all the things, just reference services, things like that. But again, realize that there are some challenges with it and uncertainty with the plans, and so that is a bit of a sticking point, and we'll continue to work. So just so members are aware of that.
Yeah, thank you. Representative Schultz, you got your answer question? Oh, Representative Liebling.
Yeah, thank you, Madam Chair. And I just wanted to ask you, Representative Mack, there's no fiscal note on this, or no appropriation on it, and I just wondered if it was, you were thinking that it might need a fiscal note at some point?
Madam Chair and Representative Liebling, my understanding would be if it relates to Medicaid, there would be a fiscal note. And so that's where the fiscal note would obviously get tied in.
Well, Madam Chair.
Representative Liebling?
Well, just looking at the bill, 3.20, medical assistance covers a payment to a health provider, et cetera, so
That,
think there it is.
Representative Liebling, that's actually what I was looking for in the bill, and thank you for finding it. So, so there it is for you, yes. So we would be looking at, and also why we would need to stop at HHS Finance to continue to talk about this, so.
thank you.
All right, and Representative Zerwas?
Thank you, Madam Chair, members. I'll be brief. I think the important thing is, and clearly, there's more negotiation that has to occur between the providers and the plan. I think it makes sense that the origination site has to have some type of payment or compensation. It's a two-way street, and you can't do telemedicine from remote areas of the state and not somehow pay for the equipment located out there. I think the important thing to do is really factor in the potential cost savings and the type of quality of care that can be delivered, utilizing, when appropriate, these telemedicine visits for a family. And I'm thinking of a family or a patient managing a persistent chronic disease. I mean, there were times years back when I was in more persistent congestive heart failure, where I was getting pulled out of school, driving from Elk River down to the Minneapolis Children's Heart Clinic, once a week, once every 10 days, and you're looking at different levels and all that stuff. So I think there's an opportunity to look at a balance for this and the type of care that you can provide and the consistency of care you can provide to a patient, to a family. But clearly, just so everyone's aware, I don't see how this bill could go forward if the health plans, if there isn't an agreement worked out along the way. That's going to be extremely difficult. So we have to find a way to get to an agreement, but to also understand, as far as where the health plans are coming from, you need to understand that there has to be some type of payment on both ends, or the system just won't work. And certainly wouldn't be vast enough to really be a benefit. So I love the idea, and I do have to say Dr. Wright was one of the testifiers. Dr. Wright was one of the physicians at the Children's Heart Clinic, so he has a special place in my heart, but, well, the half I have. The half of the heart I have. That's where his part is. But there has to be a middle ground, and I encourage both parties to keep working towards that.
Thank you. Representative Schultz?
Thank you, Madam Chair. So I obviously support this bill because I'm a co-author, but as I said at the press conference, we really need to do, if we don't do a pilot, we need to study the cost savings, the potential cost savings we get, and that study needs to be done sooner rather than later. So I would say 6 months after it's being used and implemented. And I also agree with Representative Zerwas. We need to make sure that we have negotiations between the health plans and the providers to get the lowest reimbursement. We should not be legislating or price setting here at this level. So we really do want to make sure the health plans support this bill and can have that negotiation, because I see that 17 states have no parity in terms of payments, and I think we want to go investigate what these other states, why some have full parity, some have partial, and some have no parity, and how it's going in those other states. So the second recommendation is to look at the other states to see if they have had cost savings. And I don't know if I think we should probably write that in legislation so it gets done. That's my comments. Thanks.
Thank you. Any response? We'll go on to the Representative Loeffler.
Well, thank you, Madam Chair, and Representative Mack. Sorry, the room setup means to use the mic, I can't address you. But that's the way this room works. I think that this is the future in some respects, but I also think that we're only beginning to understand where it's appropriate to use and where it isn't. And I tend to find that in an under-resourced system, and the entire system, I think, is under-resourced in many ways, that form follows finance. And so I'm just a little hesitant about opening it up so broadly and having some unanticipated consequences. And maybe that additional thinking can happen between now and the floor. Maybe it needs to happen over the interim because we do, the bill doesn't have a whole lot on definitions, and in section 4 on line 3.6, it just changes it from medical assistance covers consultation to medical assistance covers services, with no definition of what is services. Is it any service that is an MA-covered service? Is it, and could it potentially, if there's a facility fee or an origination fee, would it ask for example, the residents to go to the local clinic for a consultation with a provider or a specialist that could have otherwise been handled over email or a phone call to that clinic? And you just wait for the call back. But because the clinic has a financial interest for you to show up to get that facility fee, all of a sudden maybe you're not driving to the cities, but you're driving to your local clinic, which could be 20 miles from where your home is. And so, I don't think the intention of this is to replace that phone or email consultation, but when you put money on one route of delivery, you get it a different way. And so I think we really need to define what those services are and where they're appropriate. The other thing that I worry about is I think of a relative who was in rural Minnesota and was very pleased that a cardiologist came out, I don't remember if it was once or twice a month, to their hospital. And it was a cardiologist who had treated him in an open heart surgery here in the Twin Cities. And I just know this person would never have felt as comfortable talking with that person or felt like they were getting the same service if they're staring at a computer monitor and talking at a video camera. And so we may actually be discouraging the kind of personal access that our systems have evolved in some parts of the rural area by supporting this in a different way. And I understand for the cardiologist it might be a lifestyle improvement, but it may not be for those patients. And so I just feel like the idea of a pilot or putting some further definitions around this, I think might help us. I don't think any of us have any problems with the emergency consultations, which are oftentimes used as the examples. But I don't think I want to have this replace the simple phone call, the simple email exchange that can do the same thing. But because it doesn't have the same money with it, will suddenly disappear off of the patient clinic interaction. And so I really, don't have so much of a question, Representative Mack, although I would love to know if there's elsewhere a definition of the services or if you really intended to leave it just broadly, any service could be delivered that way.
And Representative Zerwas really wants to speak right now, so.
And Madam Chair, I do believe we have an attorney from the Hospital Association who can speak to that last part of the question also.
All right, very well.
Madam Chair, Representative, the services in this bill are only those services that are already covered by a health plan or covered by medical assistance. So it's,
And could you state your name for the records
I
as well,
apologize.
please? I'm sorry.
My name is Matt Anderson. I'm with the Minnesota Hospital Association. Thank you. So the bill does not change what is a covered benefit or a covered service under a health plan or under medical assistance. It doesn't change the health plan or medical assistance ability to set the price for what it pays for that service. It doesn't change whether or not a patient can see a provider that is in network or out of network and the consequences of that to the patient. So the medical assistance side of the bill is allowing medical assistance, which already pays for a lot of telemedicine services, so I want to be clear about that. But what it does is it allows for medical assistance to pay for those services beyond just the enumerated services that it pays for today, a limited set. It allows for a broader set of services that are already covered, already paid for, already paid at the same rate.
Thank you. Representative Zerwas?
Madam Chair, members, just briefly, I think one of the things that Representative Loeffler put out there, I just want to dispute a little bit and just and just I want to make sure we're all on the same page, that the idea that if telemedicine sites are set up around the state, that if a patient calls their physician with a question, that they would be referred to a telemedicine site rather than getting a yes or a no phone call or a medication answer or whatever the question may be, in a basic telephone call back from their doctor because there's a financial interest in it. Madam Chair, members, our healthcare providers and our physicians across the state devoted their lives to making people healthy and better and treating people. And to think that because of a $20 site fee that I'm not going to answer your medical question, I'm going to tell you to drive to your neighboring clinic so I can get 20 bucks from you. Maybe I'm just have super duper great doctors, but I'll tell you what, I've never called in on a nurse line, on an on-call line at the clinic and not had someone call back that just had very, very compassionate and helpful guidance. And to think that if we expand telemedicine, that somehow it's going to be a windfall of cash of unscrupulous physicians saying, ooh, hey, I could either help my patient out or I could send him to the neighboring clinic for $20. I just don't think that's a realistic concern to have. These folks, all they care about are treating the patients that they serve. And I think you have to realize that that's their number one intention. And a great way to do that in an economical way, in a convenient way for the patients, is to allow an expanded telemedicine program.
Representative, or did you want to respond? Okay, Representative Schultz?
Madam Chair, I would just like to
Representative
respond to that.
Loeffler.
And I was in no way impugning medical providers and their dedication to their patients. But systems do guide things based on finances. And while I don't represent a rural area, I do pay attention to what I read in the paper and what's happening in the consolidation of healthcare across the state. And I've read how rural hospitals have been taken over by larger systems, and they thought that was going to strengthen the availability of the services there, and instead they found themselves turned into a stability unit that just refers to the mothership. And so they've actually lost care delivery in their local community as a result of the efficiencies sought by the system they merged into. And so I think, it's not an intention to in any way deprive people of health care. It's just trying to figure out how to more effectively, cost-effectively do it. And sometimes those changes are perceived by the patient as not having, as actually reducing access rather than expanding it or changing it where it's how it's delivered. And I just think that as we go into this new world, and I think it's a great world, I think it offers a lot of opportunity. We just have to be careful that we're not weakening some parts of the system that are really value. And I know that my rural relative really appreciated the fact that they could have a face-to-face conversation with a specialist at that local rural hospital, and it would not have felt the same. And maybe it's a generational difference, but it would not have felt the same talking into a TV monitor. And so I'm just saying that our decisions have consequences, and we should really try and understand them.
Thank you. Mr. Anderson.
Thank you, Madam Chair. I'd just like to note a couple of quick points. One is, in today's medical environment, a physician or clinician does not get paid unless the patient shows up at the clinic. If they answer that phone call, they aren't getting paid. That's happening today. The financial incentive is much greater today to have the patient come to the clinic than it will be to get a $20 originating site fee under this legislation. So those financial incentives are already in place, and as Representative Zerwas indicated, the ability to manage workload and the ability to provide great patient care, if something can be answered via email or via phone call, that's just so much more efficient, better customer service, better patient care. The second point that I'd like to note is that face-to-face, that the bill does not change a patient's ability to choose where they go for service and which providers they see. In many rural communities, while patients may prefer to have a face-to-face visit with a psychotherapist, for example. There is no psychotherapist. And the metro area doesn't have enough psychotherapists to send one out there once a week or once every other week. And so they don't get any service at all. The ability for them to be able to say, it'd be great if I could talk with a psychotherapist via audio-visual communication and actually get service would be a dramatic improvement to the care that I'm receiving. And that's the kind of service that currently isn't paid for today. You can see a psychiatrist, but you can't get teletherapy. And we'd like to be able to expand that and be able to get access to more places in the state to get services that those people need.
Thank you. Representative Mason.
Thank you, Madam Chair. Can you tell us again, where was this bill going next?
It's going to Commerce.
Okay. I have a question. I believe there's consensus in here to pass the bill, but there's one heck of a lot of concern and reservations. And I believe there, if we're going to pass it on, there is a way of doing it like with reservation or not referring it, but getting it to the next committee. And I know I have some concern about just voting yes to get it to another committee when I know there's so many holes. So if there's somebody that can help, I've only remember doing this once, but I know it can be done. It's a way of passing the bill out, but it's with reservation or holding back the referrals, something like that.
Representative Liebling.
Yeah, thank you, Madam Chair. I think it's without recommendation that you're looking for, Representative Mason, but I think, and maybe Ms. Aves can help us, but I think that because we're not recommending a bill to pass and be referred anymore, we're just referring it. So I don't think we really need that, and
Right.
I understand your reservation, Representative Mason, and I think we do share that. I think we're hearing a lot of that here, but I personally am fine just voting to refer it to the next committee, and we've had a lot of discussion, and I don't think anyone will view that as saying that we're just saying, yes, go ahead and enact this bill, because I think we all, even Representative Mack, understands that that's not really where we're at.
Yeah.
Okay, thank you.
Representative Schultz.
Thank you, Madam Chair. So, financial incentives change behaviors. So, I think if we do any sort of analysis on the cost savings and the benefit, it might be useful to have appropriate money for, let's say, the University of Minnesota researchers to look at what we're doing now, because we got to collect data now to compare after this gets implemented. So we want this pre-post analysis to see and test Representative Zerwas's theory that, our providers are altruistic and they wouldn't charge more, but I train healthcare management students, and they're on the administrative side, and they might have a different perspective. So I think we need to see what happens, and, like Dr. Seuss says, we will see, right? But my actual question was your amendment for page 2, line 5, that says a communication between healthcare providers that consists solely of a telephone conversation is not a telemedicine consultation. And what I've learned from the testifiers is that currently, providers are not getting reimbursed for a telephone conversation, and the only thing being reimbursed is already covered by a health plan for telehealth or telemedicine. So why was this included as an amendment? And does telephone really mean a telephone? What if they use Skype or other device, and would that be also excluded?
Dr. Anderson.
Thank you, Madam Chair. That amendment was in the discussions with the health plans around changes that they wanted to make to clarify that we were not changing existing practices with respect to what is reimbursed. And the notion was, hey, if Dr. A calls Dr. B and says, have you ever seen condition X, Y, and Z? I have a patient, blah, 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 that's not a reimbursable telemedicine expense because they picked up the phone. Email, fax, those provider-to-provider communications are what currently is not a covered service under a health plan. We didn't think the bill actually needed that language because it's not covered now. It wouldn't be covered as telemedicine, but it provided comfort to the health plans, and we didn't think it changed the parity aspect that we were looking for in our bill.
And Madam Chair?
Representative Mack.
Just to that point briefly, it's my understanding, I mean, as we talk about these telephone calls, I think we just have to keep it clear right now, and as somebody who calls in with two little ones, calls into nurses' lines and doctors' offices a lot, that those things are already negotiated in plans. Those are, I'm not exactly sure the mechanics of it, but there's accounting for that nurse time, those nurses' lines, that the plans already have built into how they reimburse and how it's covered to make sure, again, that people are getting the care they need in the least expensive way. You have people that call in, and because of a good conversation with the nurse, they don't make the trip in and have an unnecessary and costly visit and a lot of tests run because it was stemmed off by a helpful conversation. So nothing about this bill changes that. That's already, well covered. I just want to clarify that. We're kind of getting off on and caught up in this conversation, and it's very different. So thank you, Madam Chair.
Thank you. I don't have any other questions on the list, and to me, this bill is just really helping our medical industry or healthcare industry move into the 21st century. And obviously, there's still work to be done, and that should continue to happen as this bill goes down its path. So Representative Mack renews her motion that House File 1246 as amended be re-referred to the Committee on Commerce and Regulatory Reform. All those in favor say aye. Aye. Opposed say no. Motion prevails, and your bill is on its way. Thank you, Representative Mack. Yeah, sorry.
That does his cat impression. So annoying.
Yeah, nice work. Oh, Ross.
No.
I just want my bill out. Wait, what one is it?
Hey, I enjoyed reading the things from you and
I'll get back to it. Okay, members, Representative Albright. We have House File 1584 in front of us, and Representative Albright will move that House File 1584 be re-referred to the Committee on Government Operations and Elections.
Thank you, Madam Chair. I have an author's amendment and an oral amendment as well.
Okay, and is your oral amendment to the A1 amendment or to the bill?
It is to the amendment, Madam Chair.
Okay, so first we will take up the oral amendment to the A1 amendment, members. And Representative Albright, why don't you state your oral amendment?
On line 2.9 of the amendment, delete the word of and insert or. And I believe Ms. Aves will assist me in explaining how that is necessary.
Okay, Ms. Aves.
Madam Chair, Representative Albright, and members. That change is necessary because I made a mistake in drafting the amendment.
Thank you, Ms. Aves. So just so everybody knows what we're doing, if you go to line 2.9 of the amendment, we're striking the word of and inserting the word or. Does everybody have that? So members, all of those in favor of the oral amendment to the A1 amendment, say aye. Aye. Those opposed, no. The motion prevails. Representative Albright, to your A1 amendment as amended.
Thank you, Madam Chair. The provision that we're discussing in the A1 amendment provides for certain situations when a nurse is not required to have a Minnesota nursing license when performing nursing functions. Examples of such are providing nursing assistance in emergency or when enrolled as a student nurse and providing nursing care. These are some currently listed as instances for an exemption. However, there are some situations which are not provided in the law that could help nurses with explicit clarification. Nurse Practice Act requires nursing facilities to be licensed as a nurse in Minnesota when teaching the theory and practice of nursing. There are times when nurses come into Minnesota on a temporary basis to speak at a at a conference or serve as a guest lecturer or provide continuing education on an infrequent basis. The use of the internet, as has just previously been discussed with File 1246, is becoming more prevalent, more widespread, and the use of nursing education over these technological wonders is now being provided to students in a classroom setting. Thus, the nursing faculty people may be in another state teaching over the internet to a student in Minnesota, requiring faculty who teach nursing in Minnesota to have a Minnesota license, even though that faculty person may never physically come to Minnesota, may not be congruent with technology and education today.
And Representative Albright, just briefly, I understand you're talking to your bill as a whole
Yes.
at one, so why don't we
With
just
that
make sure
being
we get
said,
it in order?
move it.
Yeah, we will move the A1 amendment just so that the bill's in order.
Thank you.
The order that you would like it. So members, all those in favor of the A1 amendment as amended, please say aye. Aye. Those opposed, no. The motion prevails.
Thank you, Madam Chair. I have two testifiers with me this morning, and I'll just be brief in my comments about the bill as a whole. The bill as a whole, as amended with the A1 amendment, also then allows for health-related professional boards to suspend a professional license and ability to practice and the ability to practice when an individual has violated a state statute or rule that the health-related board is empowered to enforce. The board will order a temporary suspension. When this occurs, the board must specify the reason for the suspension and must include the statute or rule that has been violated. This will take effect on the third calendar day after the order is first served by first-class mail to the address that is listed with the board. The judge then must hear the case, issue a report and recommendation to the board within 30 days of the final case hearing. If there is a delay in the case, the temporary suspension will still remain in effect until a final decision has been made. And with that, Madam Chair, if you would indulge me to request the testifiers to come forward.
Okay, a first testifier is Ms. Martinez from the Minnesota Board of Medical Practice. And if we could just keep testimony to about 2 minutes, we'll kind of keep that trend throughout the day, members, just to try to keep things moving. So welcome to the committee and thanks for being here.
Thank you, Madam Chair. My name is Ruth Martinez. I am the Executive Director of the Board of Medical Practice. Appreciate the opportunity to speak to you about this bill. I think Representative Albright has given a nice overview of the bill. I'd just like to make a couple of points of emphasis. This is just some cleanup to really align already existing processes, internal board processes with contested case hearing processes that we are obligated to go through when we do a temporary suspension action. And we worked collaboratively as a group of executive directors of the health-related licensing boards to draft this language. We also consulted with the chief administrative law judge and with the attorney general's office. And so we feel that we have some good housekeeping changes to just align. And really, I would just like to point out that we're not adding layers of process to this. We are just tweaking the timeline for getting through the processes of taking an action, conducting an investigation, going through a licensing due process, contested case hearing, and allowing time to receive a report back to take final action. Thank you very much.
Thank you so much. And we'll move to our next testifier, and if there's any questions, I trust you'll be nearby. Welcome to the committee. If you could introduce yourself and proceed.
Yes, thank you, Madam Chair. My name is Shirley Brecken, and I'm the Executive Director for the Board of Nursing. Representative Albright did a great job explaining to you what is in this amendment. And I think the important thing to recognize is that the board already has certain exemptions for when a nurse does not need to have a Minnesota license. This brings the Nurse Practice Act in more alignment with what's happening today. The most important one is that it's not unusual today for a student in Minnesota to be enrolled in a nursing education program that is located in another state, and the coursework is being delivered through the internet. This would provide an exemption for the faculty person to not have a license in Minnesota, or not be required to have a Minnesota nurse license, if they are delivering didactic or theory content in a course. If they are responsible for a clinical course where the student is taking care of a Minnesota patient, they would be required to have a Minnesota license. It also just clarifies that if they're in the state to provide a lecture at a conference or an in-service education, that they, and it's a temporary instance in which they are in the state, they would not be required to have a Minnesota license. It's a similar provision to what's in the Board of Medical Practice Act, in that if a physician is consulting or coming to Minnesota to teach a course, that they do not have to have a physician's license in Minnesota. And for that, I'd answer any questions.
Thank you. Members, are there any questions? Representative Liebling.
Thank you, Madam Chair. And Ms. Brecken, I'd like to ask you about the other part of the bill, not the amendment. And as you know, last year, we did a lot of work on this section of law, trying to strengthen the hand of the Minnesota Board of Nursing to be able to deal with problem nurses. And we did a lot of work on this language. I'm looking at the language in the bill, and I've been shown this by the Board of Medical Practice. I think this is good cleanup and strengthening language. I don't have any problem with that. But I had understood that you had taken our, the language that we did pass last year, and that you had viewed that as not strengthening the hand of the board. And I'd like you to comment on that now, since we're here talking about this very same language. Did I get that wrong? I'd like to know whether you think that what we did last year and what we're doing here has strengthened the hand of the Board of Nursing in dealing with problem nurses, so that, do you now have what you think you need in order to stop a dangerous nurse from practicing while you move through the process?
Ms. Brecken.
Madam Chair, Representative Liebling, I'm not sure of the source of your comment, Representative Liebling. The board has, in fact, taken more temporary suspension actions in this past year than it had in the previous years put together. So I think clearly it did strengthen the tools that the board had available to it to deal with situations when there was a concern that continued practice would be a risk of harm to the public.
Okay.
Representative Liebling.
Thank you, Madam Chair. Thank you, Ms. Brecken. I'm glad to hear that, because, as you know, this was a response to some pretty touchy situations that occurred where people were concerned that nurses who were, in fact, a danger to the public were continuing to practice. And while we know that's very few nurses, it's in the interests of the entire profession that we make sure that the bad apples are stopped, not to mention the interest of public safety, to make sure that the board has the power that it's supposed to have, because after all, the whole purpose of licensing, or one of the biggest purposes anyway, is to make sure that the safety of the public is protected. And so I certainly hope that if you feel at some point that the board does not have the tools it needs to protect the public safety, that you will be coming back to the legislators, whether me or Representative Albright or somebody else, and letting us know that, because it's certainly something that we all want to make sure we are on top of. So, thank you.
Ms. Brecken.
Madam Chair, Representative Liebling, thank you for your comments. And as you know, the Office of Legislative Auditor has been doing a comprehensive evaluation of the Board of Nursing discipline function or complaint resolution functions. I may or may not have seen that report will be released next Thursday in the House Health and Human Services Finance Committee. I expect that there will be some recommendations that would require legislative action, in that report, and that we'll look forward to working with you and other legislators to make that happen.
Thank you.
Representative Freiberg.
Thank you, Chair Mack. Excuse me. Not sure if this question is best directed at Representative Albright or somebody else who may have assisted with drafting the bill. I just had a question about the bill language here. specifically lines 1.11 and 1.12, the language that's being added there. If you look at the way the statute's worded right now, basically a health-related licensing board can take action when it receives a complaint and has probable cause to believe continued practice by the regulated person presents an imminent risk of harm. So it's they have pretty broad authority, but the way it's being amended here, it changes it to the board can take action if they have probable cause to believe that the regulated person has violated a statute or rule that the health-related licensing board is empowered to enforce. I imagine there are lots of statutes or rules that health-related licensing boards do not have authority to enforce. I'm just thinking like of criminal statutes as one example. So I'm, with the way this is being amended, I'm just wondering if there is, bad apple, to use the term Representative Liebling used, who has violated some sort of criminal statute. Would the board still have authority to take disciplinary action?
Ms. Brecken.
Madam Chair, Representative, what's not included in this provision, this is in Chapter 214. Each of the individual health-related licensing boards have their own practice acts, which would include in much greater detail what those provisions might be. And in particular, it has to do with the grounds for disciplinary action that are listed in each of the practice acts. And clearly, when you address criminal action, all of the health-related licensing boards have the authority to investigate when there is a notice of criminal action or criminal conviction that has been taken. And so they would do that under the grounds in their own practice act.
Okay, thanks.
Members, any other questions? Anyone else from the audience who wants to testify for or against this bill? Okay. Well, with that, I will renew my motion, or excuse me, Representative Albright will renew his motion that House File 1584 as amended be re-referred to the Committee on Government Operations and Elections. All those in favor, please say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Albright.
Thank you, Madam Chair and Committee.
Okay, members, sorry, just in consultation with members around the table, we are going to take a quick lunch break. It's going to be very quick. I'm going to have everyone try to be back here by 12:20 to take up the next bill, which is House File 1208, Representative Zerwas's bill. But with the cafeteria being open still, I just want to make sure members have an opportunity to get what they might need to get or somewhere nearby the Capitol, and then be back, and we will take up the rest of the afternoon's agenda and keep moving. So with that, members, we are going to be in a brief recess until 12:20.